sure you sign in online, or the sign-in sheets if you're in person. For the CUs, you have to sign in for the AM and PM portion of the training. So our next presenter is Kelly Kronsberg. She's with Mountain View Hospital, and she is a pharmacist. She currently practices at Mountain View Hospital as an infectious disease pharmacist and antimicrobial stewardship program lead. She earned her Doctor of Pharmacy degree from the Oregon State University College of Pharmacy in 2019, followed by relocation to Las Vegas to complete a PGY1 pharmacy practice residency at the University Medical Center of Southern Nevada, and PGY2 infectious disease pharmacy residency at Mountain View Hospital. She is board certified as a pharmacotherapy specialist and infectious disease pharmacist. Outside of Mountain View, Dr. Kronsberg serves as adjunct clinical faculty at the Roseman University College of Pharmacy. She is also an active committee member within the Society of Infectious Diseases Pharmacists and the American College of Clinical Pharmacy. Her areas of interest include quality improvement, education, and multi-drug resistant organisms. So I present to you Dr. Kelly Kronsberg.
Thank you, Kamisha. And it sounds to me like the microphone's working, so I'll go ahead and kick things off. Welcome back from lunch. It seems like we still have everyone, so thank you for coming back for this. Hopefully everyone's still awake. And as a pharmacist, I'll be talking about the treatment of carbapenem-resistant organisms. We're all very familiar with preventing transmission, which is very important, but treating the individual patient is essential as well. I have nothing to disclose except that I'm excited to be here today. At the end of this time together, I hope that you are able to understand the impact and prevalence of carbapenem-resistant organisms, the different mechanisms of resistance that these gram-negative bacteria can utilize, including stratifying carbapenemases or beta-lactamases by their Ambler classification, and how we can treat these organisms. So I will have a few assessment questions, and I wanted to introduce them at the beginning to be mindful of as we go through. So the first question is, what class of antibiotic do carbapenemases affect? The second question that we'll review at the end is, which of the following Ambler classifications does Klebsiella pneumoniae carbapenemase, or KPC, belong to? The last question is, which of the following options has activity against the class B metallobeta-lactamases, such as New Delhi metallobeta-lactamase and Verona integron-encoded metallobeta-lactamase, when used by itself? So I like to start off with the building blocks and build upon those as we go through this hour together. So I have a legend here, and this will come up a few times during the presentation. So I have the drug represented by a square or a diamond, depending on how you turn it. The enzyme represented by scissors, thinking about digestive enzymes that help us break things down. A modified drug after the enzyme has gotten to it, and the drug's target site. We can see that the square would fit very nicely into that target site, and our bacterial cell wall. So for the purposes of our discussion, the drug target site is going to be embedded within the bacterial cell wall. And without worrying about those enzymes, the drug can just reach its target site and do its job and affect this bacteria. The next layer of complexity that I want to add as we talk about gram-negative organisms is what this difference is. So for the gram stain test, we first apply crystal violet to the bacteria, which turns everything purple. And as you can see, the cell wall on this gram-positive one is thicker compared to the gram-negative bacteria, which holds true in real life. And we can still see our drug targets are in there too. So the gram-positive bacteria hold on to that crystal violet when the stain is washed away. But it's not helpful for us to look at half purple, half clear bacteria. So we apply safranin as the counter stain so that gram-negative bacteria appear pink. And it's due to that thickness and thinness of the cell wall. One of the other unique components of gram-negative bacteria that differentiate it is that it has the outer membrane that I put on here in pink, and there's a gap between that outer membrane and the bacterial cell wall called the periplasmic space. So when we apply that to our picture, our drug needs to cross through that periplasmic space in order to reach its target. And this is where the enzymes live. And this is more unique to gram-negative bacteria as a mechanism of resistance, because thinking about the gram-positive bacteria, those enzymes just have to be released into the world. Whereas for gram-negative bacteria, they have this confined space where they can store it. I like to think of it as a moat, and the alligators in the moat that's protecting the castle from the drugs. And just as an example, the scissors are cutting up the drug, modifying it, and then it no longer binds to its target site. And so that's what's going on for this mechanism of resistance. The other foundational component that's going to keep coming up is drug infusion strategies and how a drug is efficacious in terms of its pharmacokinetic parameter. So the first would be when it's administered as a bolus, it achieves high concentrations that I have represented on the y-axis here. And then on the x-axis, I have time. And the red bar is the minimum inhibitory concentration that we want to be mindful of for the drug to be efficacious against the bacteria. And this is going to vary from drug to bacteria and organism to organism. But for this, I just set it at 20. These numbers are somewhat arbitrary, simply to illustrate a point. So for this example, our drug given as a one-time dose achieves a pretty high concentration, and then we let it fade out. And we might want this for a drug that works best by achieving that high concentration, but might be more toxic. So we want to ensure our patient goes a period of time without having high levels of it. The next strategy would be an intermittent infusion, where maybe we administer an IV drug over an hour. So the peak doesn't get as high because we're taking longer to infuse it. And for all these examples, I have the half-life set at 1 hour. So 50% of the drug goes away at each hour mark on this graph. And we can take note of this time below the MIC. Whereas if we extend infusion to a 3-hour one, the peak is even lower because that drug is infusing over a longer period. But as it clears out at that same rate, there's even less time below that MIC. So for drugs that are concentration dependent and then you need that constant presence in order to work, extending the infusion helps make them be more efficacious and is a strategy that we can use to expose patients to less medication, purchase less medication, and simply administer it as a longer infusion and use that strategy. Now you might be thinking, why not just give it continuously, right? That seems like the best of both worlds. There's a couple of concerns here. One, that drugs are chemicals, so there's chemical instability, especially with some of these beta-lactams that we'll be discussing today. The other thing is using up a patient's IV line for 24 hours when perhaps we need to use it for other medications. So there's some feasibility concerns as well. Mentioning beta-lactams, I did want to briefly show the different classes of antibiotics that we may consider for our gram-negative bacteria. So beta-lactams are predominantly going to be our backbone, and I will be discussing those in much more detail very soon. Fluoroquinolones are another one that we commonly see. So this would be our ciprofloxacin, levofloxacin, moxifloxacin. And we do use these quite a bit. As mentioned earlier, there are concerns with toxicity and increasing resistance, but they still do remain in our arsenal in set situations. Sulfonamides, such as sulfamethoxazole trimethoprim, or its brand names Bactrim or Septra, can be another option in certain scenarios, but it's not necessarily first line for a lot of cases. Same with tetracyclines, which would be our doxycycline, tigacycline, minocycline, eravacycline. It can be an option if we aren't able to use one of these other ones, but typically not something that we go for the first line for our more resistant or systemic infections. On the bottom here, I do have aminoglycosides and polymyxins. So our aminoglycosides would be gentamicin, tobramycin, amikacin. Polymyxins would include colistin. These are no longer used as backbones of therapy and more so adjunctive if the patient requires it due to their high toxicity and just poor established track record of efficacy compared to our other options like beta-lactams and fluoroquinolones. Not on this list would be one specific for the urinary tract, such as fosfomycin or nitrofurantoin, but I did want to mention they can have some efficacy for bladder infections as well. Focusing on our beta-lactams, there's 4 subcategories here. We have our penicillins, cephalosporins, carbapenems, and our monobactam. And if you may not be familiar with these in your day-to-day, penicillins all end in cillin, ampicillin, amoxicillin, piperacillin. Cephalosporins all start with ceph, cefazolin, cephalexin, ceftriaxone, cefepime. Carbapenems all end with penem, meropenem, imipenem, ertapenem, and the monobactam is astrianam that we currently have. These are our 4 major groupings. I know drug structures are scary, but I'm really putting these up here just to prove a point that they all have the same beta-lactam ring, illustrated there by the box with the nitrogen and the oxygen coming off of it. And this will come up again. And then question marks kind of differentiate the different side chains that our different drugs have. And you'll notice that the penicillins, cephalosporins, and carbapenems all have a second ring attached to that beta-lactam ring, but not the monobactam. And that's what makes the monobactam unique, is there's only the one beta-lactam ring. Moving on to the beta-lactamases, it's not surprising that these can be categorized in the same way as the drugs that they affect. So you have penicillinases that only affect penicillin, ampicillin, amoxicillin. Cephalosporinases, since they're more broad drugs, these are also more broad beta-lactamases, and they affect the cephalosporins and the penicillins. And if they affect third or fourth gen cephalosporins, then we know them as extended spectrum beta-lactamases, or ESBLs. And lastly, we have carbapenem-resistants, which of course we'll be talking about much more in this next hour. To explain what a beta-lactamase does, I wanted to bring up our ring that we're now very familiar with. And our enzyme, I didn't want to draw out a beta-lactamase protein. And good old H2O, water, is what it uses, and it breaks open that ring. And you can see where the two H's and the O are added to that opened ring, and that renders the drug unable to work. So that's what our beta-lactamase is doing to our drug molecule when inside the patient. To bring our chemical structures back, X, we can see that that occurs to all of them when a beta-lactamase is present, if the beta-lactam is susceptible to that beta-lactamase. Now that we've introduced all these terms, our figure is back renamed, where our drug is our beta-lactam, our enzyme is our beta-lactamase, and our drug target is the penicillin binding protein, named for the original penicillin, of course. Now, wouldn't it be nice if we could just call these beta-lactamases by penicillinase or cephalosporinase or carbapenemase? Unfortunately, that's not what's done in practice. We have 4 classes. And originally, back in the day when Ambler was doing this, they were looking at the amino acid sequence, which I have no desire to go into during our time together. And they said, oh, well, these ones have a serine amino acid, and these ones have a metal. So we're going to call these serine ones class A, and we're going to call these metal-containing ones class B. There we go, 2 classes. Well, a few years later, they were like, wait, here's a new beta-lactamase, and it has a serine, but the amino acid sequence doesn't look like class A. Okay, we'll call them class C. And then a few years later, the same thing happened, and now that's how we have classes A, C, and D that are all serine, and B that is metallo-beta-lactamases that makes it unique. But really, it's the amino acid sequence that's different amongst them. I also want to talk about the strategies that we have with beta-lactamase inhibitors. So there's 3 classes here. The first one are ones that contain a beta-lactam core. These are also known as suicide inhibitors because they essentially sacrifice themselves in order to irreversibly bind that beta-lactamase so that it can't work on any of the beta-lactams. And this works against class A and class C. The second one is the diazobicyclooxynones, which I'm going to call DBOs. And I just wanted to put the full name up for formality. This is reversible, as are the boronic acid inhibitors, but the DBOs work against all the serine beta-lactamases, A, C, and D. The boronic is also reversible, but it only works against class A. And you may notice that there's no class B beta-lactamase inhibitors up here, which is why that there's still a challenge. And we'll talk about how we can treat them later. So our examples, clavulanate being our first known beta-lactamase inhibitor, it has the unique name because it actually came from another organism, whereas the remainder of them end in bactam because they've been synthesized. You'll know clavulanate best in combination with amoxicillin as augmentin, sulbactam with ampicillin as unison, but we're going to talk about a brand new drug that uses that as well. Tazobactam in combination with piperacillin under the brand name Zosyn. And then for the DBOs, there's avibactam, relibactam, and durlobactam, and I'll be talking about all of these more later on and how they're currently marketed. And our boronic acid inhibitor is only vaborbactam, and it has that bor for that boronic acid inhibitor in there. And I'll also be talking about that drug against class A. Now coming back to our picture, I added in our beta-lactamase inhibitor. We can see it's paired with our beta-lactam. It's able to detach. It's able to distract the enzyme and bind it so that the drug can still work. But even if the beta-lactamase isn't there, the beta-lactam in combination with the inhibitor is still able to bind the target site as well. So it's not going to impair the drug's functioning in any way. This has been a little bit technical. Let's take a break. So another way to think about it is if we have our car on our way to our target, and if everything goes well, we reach there, no issues at all. But sometimes there might be barriers in the road that can damage part of the car. Our car can't reach our target. But if we think about maybe a different vehicle or different tires could help us overcome that and reach our destination, then we're still able to do so. So we're just essentially enhancing our current drug with better tires in order to not fall susceptible to that. But now we have to go back into the technicalities, back to the carbapenemases. So the question is, why is this worth our time today? Well, in 2020, we had the highest rate, as you can see on this map, 15% of the carbapenem-resistant Enterobacterales. So the national average at this time was 2.7% in each state. We were at 15. This is for 2020. Puerto Rico did beat us. They were at about 24%, but I'm not sure this is a title we want for second highest. So it's definitely worthwhile to discuss how we can treat our patients. Coming back to the Ambler classifications of beta-lactamases, AMPs class C contains the AMP-C beta-lactamases, which are actually only cephalosporinases. So I'm not going to spend any more time talking about the class C because they aren't relevant to affecting carbapenems. I do have a flowchart here trying to think about how we can make this understandable at a clinical level when they're looking at the amino acid sequences. So as I mentioned, the serine versus the metallo-beta-lactamases, class B are those metallo-beta-lactamases. Class C can't hydrolyze carbapenems. They can't use that water, the hydro, to open that bond, which would be the hydrolyzing. So class C is ruled out that way. And then we talked about clavulonate being a beta-lactamase inhibitor, and class A can be inhibited by those, but class D can't. And you might be thinking, well, why not just use augmentin for all of those then? And that's because this is in a lab scenario that can use much higher concentrations of clavulonate than would be safe to achieve in our patients, but that would be one way to differentiate them. So we have our three classes of carbapenemases, A, B, and D. Class A contains our Klebsiella pneumoniae carbapenemase, or KPC. Class B contains our New Delhi metallo-beta-lactamase, or NDM, as well as our Verona integron-encoded metallo-beta-lactamase, or VIM. Class D are the oxacillinases, which I find oddly named since they work against carbapenems and not just oxacillin. But I'm going to call out OXA48 specifically and then lump the rest of them together. And that will make sense as we talk about the drugs. And KPC has historically been our most common one as our class A carbapenemase. Kind of makes sense. Class A was discovered first. But in recent years, it's actually trending down. So it's still our most prevalent, but the class B NDM and the class D oxacillinases are actually increasing in prevalence as well. So I just found this an interesting point to discuss as we talk about how to treat each type of carbapenemase. Let's jump right into the drugs, why don't we? The first one is meropenem with vaborbactam, which, as you'll recall, is our boronic acid inhibitor, and it works against class A. This is going to work against our KPCs. The normal dosing is 4 grams of vabomere and equal parts of the meropenem and the vaborbactam, and it's given IV every 8 hours, administered over 3 hours, which is a callback to our extended infusion and optimizing that time above the MIC. It does require renal dose adjustments, which is something to be mindful of, but not hepatic dose adjustments. There's 2 warnings affiliated with this medication, and they're based on the meropenem component of it. So these are actually carbapenem warnings, not specific to vabomere. So seizures have been reported with carbapenems, and they do have a significant drug-drug interaction with valproate or valproic acid, where they decrease that free serum concentration. So if you have a patient who's using that to prevent seizures, you may need to consider another agent if possible, or initiation of perhaps levetiracetam or Keppra to provide the patient additional seizure protection while they're receiving this medication, or simply choose to monitor. That's sort of a physician preference conversation. Next one is imipenem-cilastatin-relebactam, which is marketed under the brand name Ricarbrio. This one does work against class A. I know that I mentioned relebactam as a DBO can have some class D, but I wasn't able to find any studies about that yet, so perhaps it simply hasn't been studied. But for right now, we have it approved for class A, which is our KPC. And I did want to pause here because we've talked about the penems, we've talked about relebactam, but what's cilastatin? Because that's always thrown in there with imipenem, as you may be aware. And so that actually isn't for the patient's cholesterol. It's because there's a renal dihydropeptidase enzyme in the kidneys that is breaking down the imipenem and causing the drug to leave the body sooner. So cilastatin prevents that breakdown and extends the half-life of imipenem, which allows us to give it less frequently and keep more drug in the patient's system. So that's the role of cilastatin here. And this is normally dosed at 1.25 grams, so 500 milligrams of the imipenem and the cilastatin, and a little bit less of the relebactam. This one is given every 6 hours over 30 minutes. So if we're thinking back, this is more so our intermittent infusion, but by shortening that dosing interval, we're able to then have a higher time above the MIC. So instead of extending the infusion, giving the drug more frequently is another strategy to ensure that we have adequate time above the MIC that our beta-lactams need to work. It does require renal dose adjustment, once again, not any hepatic dose adjustment, and it has the same carbapenem warnings that Vabomere has, since imipenem is once again a carbapenem, so seizures and the valproic acid drug-drug interaction. Next, I have ceftazidime with avibactam, which is under the brand name Avicaz. It works against both class A and D, since avibactam is a DBO. So it's going to work against KPC and specifically OXA48-like is what it's approved for, not the other oxacillinases, but that one specifically. So it's given as 2.5 grams of the Avicaz. If you're familiar with ceftazidime alone as Fortaz, its normal dosing is 2 grams every 8 hours. So we're adding on that 500 milligrams of avibactam to our normal regimen, administered over 2 hours. IDSA in their antimicrobial resistance guideline recommends giving it over 3 hours. There was not an evidence-based recommendation here. It was simply done for consistency and to follow that logic of, oh, well, this will give even more time above the MIC if we give it over 3 hours instead of 2. So I did want to make that call out in the difference between what the manufacturer is recommending and what IDSA is recommending. It does need renal dose adjustments since it is a beta-lactam, but no hepatic dose adjustments. Now, ceftazidime is a cephalosporin instead of a carbapenem, but it does still have a seizure warning, which we do see in some of these later generation cephalosporins, such as cefepime as well. And this is especially a concern in renal impairment, especially if it's not appropriately renally dose adjusted. So that's something to be mindful of and a potential risk if a patient's kidney function is worsening and we don't decrease the amount of drug that we're giving them. There was also a warning about decreased clinical response in patients with baseline renal dysfunction that's within the package insert. But there was actually 2 studies that were done. And in the first study, they saw this and they looked at the patients in this cohort of creatinine clearance from 30 to 50 and said, well, actually, they weren't getting enough drug. So in the second study, they ensured all the patients were receiving the right amount of drug and that difference in clinical response was no longer seen. But since it was in one study's result, it was included as a warning in the formal labeling, and I wanted to mention it here. A brand new drug on the market this fall that I wanted to make sure to include. So this is our sulbactam with durlobactam. You might be thinking, hey, that's 2 beta-lactamase inhibitors. Where's the beta-lactam in there? Well, sulbactam actually works as a beta-lactam against Acinetobacter baumannii, which I know that we're all very familiar with down here in Las Vegas. So this drug, Xacduro, was developed specifically for Acinetobacter baumannii. It's not approved for use in any other organism. And the durlobactam works against all those other oxacillinases because Acinetobacter makes oxacillinases. That's why it's hard to treat, but it doesn't make 48. So Avicaz doesn't work against our Acinetobacter, and we've needed another treatment option for this organism because we haven't had that many. And since durlobactam is a DBO, it also has class A activity against KPC, but once again, it's going to be restricted to our Acinetobacter baumannii. We aren't going to be able to use it for our KPC-producing Klebsiella or E. coli, or at least it's not approved for that. Our normal dosing is 2 grams, which is 1 gram of each component of it, given every 6 hours, administered over 3 hours, optimizing that time above the MIC. I do want to call out for this drug that they have a enhanced renal function change in dosing, where then it's given every 4 hours instead of every 6. So the 6 is not the maximum dose, but it's the base dose that was approved. This is one of 2 drugs that I've seen have that strategy of where we might need to increase. I will say, as a pharmacist, as someone who cares about drug waste, my favorite thing about this is that no matter the patient's renal function, the dose is always 2 grams. We only change how frequently we give it with improving or worsening renal function. So that's something that I like about it personally. There wasn't a whole lot of warnings or monitorings that came out, but I did want to call out potential increase in ALT, so monitoring liver function tests. That was seen in 11% of patients, and typically when it's above 10, it catches my eye. This is brand new, end of September became available for purchase, and I'm sure we'll start hearing about it in all of our facilities. I already have. So we've covered all of our Class A and our Class D options, which was all of our beta-lactamase inhibitors that we talked about. So what about Class B? What do we do for these guys? Well, they actually don't target aztreonam very well since it's a monobactam, because one of the ways that drugs can essentially protect themselves from these enzymes is by having side chains that protect their beta-lactam ring. And so for whatever reason, aztreonam is spared, which is great if the metallo-beta-lactamase is by itself. Unfortunately, it's not. It tends to have friends along with it, other ESBLs, that then do work against aztreonam. So what we do is we empirically give it in combination with ceftazidime avibactam, and the ceftazidime is not doing anything in this scenario. It's the avibactam protecting the aztreonam, and that's our empiric regimen of choice for the metallo-beta-lactamases. Aztreonam is given as 2 grams IV every 6 to 8 hours, administered over 30 minutes. Once again, IDSA recommended 3 hours to optimize that time above the MIC, so that would be one notable difference when you're using it here. It does need renal dose adjustments, and it's pretty well tolerated from what I've seen and what's been reported. The other drug that I haven't mentioned yet that doesn't have a beta-lactamase inhibitor is cefiderocol, which is under the brand name Fetroja. And as I mentioned, the drugs can have side chains that look like certain things that protect it. So cefiderocol actually took inspiration from ceftazidime and cefepime and took their side chains and put it onto its molecule. But what's really interesting is the way that it works. So it tricks the gram-negative bacteria into thinking that it's iron. And the gram-negative bacteria wants iron to help build up its strength and work more effectively and essentially harm our patients more effectively. And so cefiderocol is able to sneak in through the specific iron siderophore is the name for that access. And the bacteria thinks it's taking up iron, but it's taking up the drug that then kills it, which is why it has the FE for iron and Troja for Trojan horse, is how you can connect its brand name to its mechanism of action. And essentially, the thought here is that it's such a big molecule that the beta-lactamases can't really get to it. So it's not as susceptible for them to reach that beta-lactam ring and open it up and hydrolyze it. So that's the goal with Fetroja. This is the other one where we have our base dosing of 2 grams IV every 8 hours, administered over 3 hours, but you actually have to increase that to every 6 hours in patients with really good renal function. So this is the other one I wanted to call out to be aware of. As I mentioned, for them to need to increase the dose, it also requires renal dose adjustments down, no hepatic dose adjustments. I said that it took inspiration from ceftazidime and cefepime, which were the 2 cephalosporins I mentioned as being affiliated potentially with seizures if they weren't dosed appropriately in renal impairment. So we also see that warning here on cefiderocol due to that chemical structure. The other warning that I think is quite eye-catching as a flag is that in the studies against carbapenem-resistant organisms, where this is really our place to use this, they actually saw increased all-cause mortality when compared to best available therapy. Now, this is all-cause mortality. It's not necessarily infection-related mortality. There were likely many other things going on with these patients that have these sort of organisms in them, but I would say it is a flag and something to pay attention to. My personal practice is, as a pharmacist, I want to play it safe, and I don't have the ability to test cefiderocol susceptibility at my facility. So if Vabomere or Avicaz shows susceptible, I'm going to go with that known susceptible agent and use cefiderocol if it's a polymicrobial infection or if the patient appears to be failing those. So that's essentially my best available therapy compared to reaching for this one as first line as my personal practice. Now that we've covered our carbapenemases, let's review how to treat them. So for aztreonam, it's going to work specifically against those class B metallo-beta-lactamases, but not class A or class D. And the rest of them essentially have some activity against class A, our KPC, our A team, our most common. That's going to be Vabomere, Ricarbrio, Avicaz, kind of Zacdero if it's present in Acinetobacter, and cefiderocol. And once again, Cefidrocol is thought to work against all the classes. We use Avicaz for class B to protect the aztreonam, so I kind of put it in yellow there. And then it has that OXA48-like activity, but not the other oxacillinases that Zacduro has. And then Recarbrio and Vabomere are not going to work against class B or class D. That's our carbapenemase review. And the other thing is that we've talked about the beta-lactams, but these beta-lactamases are only going to work against the beta-lactams. So if there's no other mechanism of resistance present, any of these other drugs are still fair game to treat our patient. We could still use a fluoroquinolone if they're susceptible, or Bactrim or a tetracycline, which is why we might reach for those rather than one of these more broad-spectrum beta-lactam agents. To include infection prevention, even though I'm certainly not the expert on this in the room, the CDC does recommend for these that it would be contact precautions as a multi-drug resistant organism. That's not our only mechanism of carbapenem resistance. That would be too easy. So now we're adding in porins, and carbapenems have to go through porins or channels to enter the periplasmic space on certain organisms. And we see this actually the most on Pseudomonas. So the bacteria is like, I'll just take away your access. Now you can't reach your penicillin binding protein because you can't get through my cell membrane. And so this is our other major mechanism of carbapenem resistance that we see particularly in Pseudomonas. And on a susceptibility panel, you'll recognize porin resistance because the other beta-lactams aren't affected. The penicillins, the cephalosporins, they can still get through the membrane, just not the carbapenem. And I will say that I do see this mechanism of resistance down here and have a lot of discussions that this is not a carbapenemase. It would be all resistant. With the potential exception of aztreonam, if it's a metallobeta-lactamase, or if it happens to be a class A and we're able to get Vabomere or Recarbrio, we would see that on the susceptibility panel. It can use it for clues as to what the bacteria is doing. I mentioned that this is mostly in Pseudomonas. So we're going to rule out our carbapenems for our porin resistance. We've talked about aztreonam. I'm not going to spend any time on Zosyn or Cefpime or Ceftazidime. We talked about Avicaz, Fatroja, but that leaves Zerbaxa. This is a new one that I want to talk about, cephalosporin based since it starts with Ceph. Tazobactam, we know that is our beta-lactam core, and this is specifically for Pseudomonas because it's going to overcome that porin-mediated resistance, which we might also think about Avicaz with Ceftazidime. That's not going to be affected either, right? So Zerbaxa is 3 grams, is 2 grams of the ceftolozane, 1 gram of the tazobactam every 8 hours, administered over 1 hour. This is another one where IDSA is recommending some different things. So IDSA says, give it over 3 hours, give everything over 3 hours, optimize that time above the MIC. And they also recommend this 3-gram dose for all infections outside of cystitis. Whereas if you look at the manufacturer labeling, the 3 grams is only for pneumonia. So I would say clinical judgment on how sick your patient is or which guidance you prefer to follow. I will say 3 grams is currently the IDSA recommended dose, just using that knowledge of the pharmacokinetic parameters, time above the MIC. It does need renal dose adjustments, and it also has a warning for decreased clinical response in patients with renal dysfunction. This one did not have the same disclaimer that Avicaz did about, well, in the second study, it was dosed right. So I'd say just keep an eye on your patient's clinical response and if a need for a change to another agent is indicated. Here, back to our table with our new drugs added and our new mechanism of carbapenem resistance. So for the reduced porins, mentioned the Zosyn, the Cefpime, the Ceftazidime, those aren't affected. Those will still work if that's the only thing that the Pseudomonas is doing. Whereas aztreonam, it's not going to be affected by the porins either, and it's still going to work against those class B. But our Vabomere is going to be affected by the porins since it is a carbapenem. And now you're probably thinking, well, did she mess up and put a check mark for imipenem and Recarbrio? Well, Recarbrio actually does still work against the Pseudomonas because the Relibactam is the DBO beta-lactamase inhibitor instead of the Vaborbactam boronic. So Relibactam is much better against the class C cephalosporinases I said I wouldn't talk about, but Pseudomonas has a lot of those in that periplasmic space. So essentially whatever imipenem is able to get through, the Relibactam protects it so efficaciously that it's able to still work against Pseudomonas when you otherwise wouldn't expect it to. And then for Avicaz, we're just check marks all the way through, even though we talked about for the metallobeta-lactamases, it's not actually acting, it's only protecting the aztreonam. And for the class D, it's going to be that 48 specific. For Zachduro, it's going to be Acinetobacter specific, so not class B, kind of class A. Cefiderocol, once again, all the way through because it's a cephalosporin and it's proposed to be resistant to that beta-lactamase. And then Zerbax is going to be specific for Pseudomonas with reduced porins. I do want to give the caveat as we're kind of coming to an end on this slide that these are what options I would consider to be on the table as well as the non-beta-lactams. So of course it's going to depend on, is the organism having multiple mechanisms of resistance or is it really just this one? And I would always confirm with susceptibility testing. I mentioned as a pharmacist, I always want to play it safe and have an S next to it on that susceptibility panel if I'm using it. Summary. The most common mechanism of carbapenem resistance is via carbapenemases. And these can be class A, B, or D. And class B is specifically the metallo-beta-lactamases. Class A, we have Vabomere, Ricarbrio, and Avicaz. And Avicaz also works against class D, OXA48-like. Zero is specifically for Acinetobacter and does have some class A and D activity, all those other oxacillinases that are Acinetobacter produces. Cefiderocol is resistant to hydrolysis by all classes of carbapenemases. Pseudomonas is more likely to reduce the porins rather than produce carbapenemases. And this isn't going to affect penicillins or cephalosporins. So it's just going to prevent that access to the periplasmic space. Could always confirm susceptibility. And just because I have it on the chart as a check doesn't mean it's a check for a specific patient. Coming back to our assessment questions. Which of the following antibiotic classes are impacted by carbapenemases? Beta-lactams. I taught all you that. Which of the following Ambler classifications does KPC, our Klebsiella pneumonia carbapenemase, belong to? A. Woohoo. And lastly, which of the following options has activity against the class B metallo-beta-lactamases as a standalone option? D. Cefiderocol. Perfect. My student passes her. Thank you for your time today. I would be happy to take any questions. Yes. Oh. I'll take the opportunity for some water after talking.
Hi, thank you for the wonderful presentation. I have two just quick questions. One, about the Acinetobacter. If we're seeing Acinetobacter that's essentially like pan-resistant, but doesn't have a carbapenemase producer that we've identified, are you also using that?
The Sulbactam, Durlobactam
Yes.
for pan-resistant.
Yeah, is that the same
Acinetobacter.
thing? Would you use that also, or are you doing something different?
That is a great question. And you mentioned that you hadn't identified a carbapenemase. So our Acinetobacters tend to produce OXA23, OXA51, and OXA58. So my first question when you say it doesn't have a carbapenemase is, are you testing for those?
Okay.
Because that certainly isn't on my panel of the resistant genes, but that is especially even Las Vegas's Acinetobacters are known to produce that, which is where that Sulbactam, Durlobactam would come into play. The current IDSA guidelines haven't incorporated yet, so currently IDSA is still recommending a combination strategy with an advanced generation tetracycline, such as tigacycline or minocycline, and avoiding the beta-lactams, using high-dose unison to optimize the sulbactam. So you might see 9 grams every 8 hours or 3 grams every 4 hours to get as much sulbactam into the patient as we can. In that situation when we're using unison, the ampicillin isn't doing anything. It's all the sulbactam. So I would consider addition of the Durlobactam. I will say personally in my practice, I'm still seeing a really good response to unison-based combination therapy. But in a patient that I felt wasn't responding, I would consider use of that, and I have acquired it for my facility.
Okay, thank you. And then my second question was about some of these new drugs that you were teaching us about. Are they noticing resistance mechanisms to those at this point?
Yes, so there is a potential for resistance, which is why I really wanted to emphasize these are the drug options that can be on the table, but they aren't guaranteed to work. So I'll give you, well, the example I was thinking of is kind of encompassed in what I presented, but essentially the short answer is yes. There can be other types of resistance other than carbapenemases that are occurring that can lead to resistance, which is why I would really emphasize the testing. Treatment emergent resistance is always a concern, especially with prolonged courses and rechecking susceptibilities after 1 to 3 weeks. If the patient doesn't appear to be responding anymore, I think that would be reasonable as well. But essentially, if you know it's susceptible, I would lean towards that. But there is the possibility. Never say never in medicine, right? Any other questions? Otherwise, I can hand it off to Kamisha. Looks like I might have put us back on track talking so quickly. Okay, thank you for your time.
Are there any additional questions from anyone?
We have no questions in the north.
Okay, thank you. Hopefully I made it clear and not confusing.
All righty. Alrighty, so I can easily introduce myself. My name is Kamisha Kazi. I'm the HEI coordinator for the state of Nevada. I received my BS in biology from the University of West Georgia in Carrollton, Georgia. And then I received my MPH from Walden University in Minneapolis. I relocated back to Nevada in 2012. I have 7 years experience in environmental health, and I've been working this position since 2013. I just actually received my Master's of Social Work last year from UNR, Go Wolfpack. So I am here to present on outbreak containment. Thank you for the little claps in here. Oh, sorry. Okay. On outbreak management and outbreak containment and management. So for our agenda today will be to review Nevada's outbreak definition, understand how transmission occurs, understand actions to prevent the spread of outbreaks, review outbreak reporting, review containment procedures, and examine the importance of inter-facility communication. All right, so what is an outbreak? So according to NAC 441A.130, an outbreak is defined as the occurrence of cases in a community, geographic region, or particular population at a rate in excess of that which is normally expected in that community, geographic region, or particular population. For your facilities, an outbreak would be anything that is, normally it's going to be 2 cases or more, or something above your baseline. So something like C. diff, you normally see C. diff in your facilities, you might have 1 or 2 cases a day that might be that are healthcare acquired. But let's say for a particular month you see 6 C. diff cases, so that is above your baseline. That would be an outbreak. We would need to be contacted for that, versus something like norovirus or flu. You might have some coughs, runny noses. You might have one person, then all of a sudden you have staff and they're all out for the same thing. Residents that are exhibiting the same signs and symptoms. So once you get past that one staff member, one patient, we will consider that an outbreak. Now, COVID is different because one COVID case is an outbreak. So with that, we would need to be contacted for COVID if it's just one person. And then auris would be multiple cases as well, more than one case. So as I mentioned here, depending on the type of outbreak, this will be defined by 2 or more cases or cases above your baseline. So transmission, and Jen covered this mainly in her presentation, but we talk about breaking the chain of transmission of infection so that we prevent patients from getting infections. Well, basically an outbreak is that chain didn't break and it keeps continuing and passing from patient to patient to patient. So the infectious agents would be, they have fungus on there, but I just did bacteria and viruses, which I guess I should include fungus. The source are your people, environment, and water. Exit are aerosols, splashes, and those are just some examples. Examples of means of transmission are direct contact, inhalation, and airborne. Portal of entry, mucous membranes, your respiratory tract, wounds, and then having a susceptible host. All of those stay intact, and we have spread, then we have an outbreak. So breaking the chain of transmission, when you look at the different pieces of the chain, so you can have contaminated equipment, coughing and sneezing of your staff members or other residents. As Jen mentioned, staff will come to work sick because we need the staff. Sometimes if you don't work, you don't get paid, and I need to get paid. So when you have those instances, when you're spreading the joy around the facility, inappropriate cohorting, we get a lot of questions about who can be cohorted together. And I know we've had instances of a patient with CRs and CRE versus a patient with just CRE. You can't cohort those patients together because they don't have all the same bugs. So working with our IP staff or calling myself or my staff on who you can cohort so that you don't transmit infections to other patients. Contaminated hands, as Jen mentioned, the hand hygiene compliance is at 50%. On one of my slides I found where the World Health Organization said that hand hygiene should be 91%. So doing those audits and really understanding your facility's compliance is important. When we do the ICARs, a lot of staff or the IP staff that we speak with, when we ask about compliance rates or do they train on hand hygiene, they always mention that training that occurs at higher. But training should be continuous, and then you have to do those audits, those secret shoppers, to make sure your staff are actually doing those things, because when you're in the work of the day, you can get caught up in your regular procedure, your regular regimen, and where hand hygiene should occur or PPE changes occur, those things don't happen. So if nobody is bringing that to your attention so that you're aware, you're going to continue in those habits that can cause transmission within a facility. Contaminated PPE. Before I got into HAI, I was in environmental health, so I inspected restaurants and hotels and things, and the health department that I worked in Georgia was right across from the hospital. And it was nothing to see hospital staff coming out at lunchtime in full PPE with their bonnets on and the booties on and all this kind of stuff. And I mean, common sense would say, well, why are you out here in that? But I didn't know the risk, because I wasn't in the world of HAI. But now I know. I was like, man, they were just, they walked out in it. Did they come back in the hospital with that? You never know. So taking your PPE off, you want to leave everything in the room where it came from. Let's just say it like that. So if you're in a patient room, you want to doff that PPE, leave it in their room, wash your hands. Alcohol-based hand rub, as Faye mentioned, is the recommended practice, unless of course your hands are soiled or you're dealing with infectious diarrhea, different things like that where you want to use soap and water. contaminated lines or catheters. So making sure you're not causing contamination of those items on the patient, that you're using appropriate hand hygiene. And gloves are not a substitute for hand hygiene. You know, when I'm sure we all are aware when we go for our own personal healthcare visits and to our doctors, I mean, I'm watching. And it's even with my children, and they come in the room with the gloves on. And so I mentioned to one of the nurses, and I said, you know, can you take your gloves off because you didn't wash your hands? And she said, oh, I washed them before I came in. And I said, well, the moment you touched that doorknob, you contaminated yourself. So can you take those off, wash your hands, and put on some new gloves? And, you know, if your patients bring that to your attention, please don't give them attitude, because then it makes them afraid to advocate for themselves. And a lot of patients, you know, when we do speak to them and we teach advocacy, a lot of times they don't want to speak up because they don't want there to be an interruption in their care. They don't want to be treated badly because they wanted to protect themselves or protect their family members if they're in the room visiting. So if they're noticing those are things that we're teaching them to do. Advocate for themselves. Advocate for your family members when you're visiting them in their healthcare facilities. So it's not them trying to tell you how to do, you know, your job. It's just them trying to protect themselves, which, you know, we all should want them to do. Lack of surveillance or auditing. A lot of times, especially with CRs, people don't want to do the point prevalence screening. They don't want to do screening at all, but that's how we identify who is in the facility. When an outbreak occurs, the first thing we're going to ask you are, has anybody been tested? You know, if it's diarrhea, have we been able to test the stool samples? Because if we don't identify the causative agent, then we have to kind of give it a blanket name, you know, GI illness or respiratory outbreak, versus being able to identify what is causing the outbreak to make sure that the patients are, number one, getting the appropriate treatment, and then number two, with EVS, you're using the appropriate cleaners and disinfectants. So if we can put a name to it, then it makes our treatment of it and how we handle those cases more targeted. So we can see those cases, you know, in quicker than kind of go on because we don't really know what we're dealing with. And as Faye mentioned, our state lab is able to test. They have a website. I think I have a link in here. Hopefully it'll work, but if not, I can send that to you. You can request whatever type of supplies that you need. Of course, things have to be shipped here to Vegas, so that, you know, causes a little time lapse, but they do, I don't know if the supplies are shipped, but when you, flown, but when you do send your specimen back, those go on a plane. They have a plane from Southwest that goes up north every day. So they collect everything, they fly it up north, and then that allows us to have that quicker turnaround time when getting your results back. But also utilizing your labs here, Southern Nevada Public Health Lab, they have a courier that does a pickup. So if you're trying to get testing done and you don't really have those resources, let us know so we can help you find the resources for that to get that testing completed and the supplies for testing. And then also lack of communication. I think Jen mentioned in her presentation, when you're receiving patients or sending patients out, the facilities need to be aware of what they're receiving. The EMTs need to be aware of what the patient has that they're transporting so they can clean their vehicles appropriately. So anytime that we're lacking in cleaning and disinfection within the facilities, within the transport units, the facility that they go to, if they have to test to find out what's going on, that further continues that chain of infection, because there's a lapse in them being able to treat that patient effectively. And that communication, as we all know, goes both ways. You know, some of you have been on call. I know College Park has been on those calls where we're trying to foster better communication between skilled nursing and acute care, and use of the transfer form, and how can we utilize that better. So when we have those calls, we need your participation, we need your input. Even if you don't want to talk on the calls, shoot me an email, and then I can make the comments for you or ask the questions so that you can get the information that you need, because that hurts you all when you receive a patient and they need to be in a isolation room because they have whatever they have, and that information is buried in a chart. You know, and it works the other way when you guys are sending patients back up to acute care for a higher level of care. So that lack of communication really hurts us in the patient care process and preventing outbreaks from occurring. So actions to prevent outbreaks. So these are kind of the statistics. According to CDC, research shows that washing hands with soap and water could reduce deaths from diarrheal disease by up to 50%. Researchers estimate that if everyone routinely washed their hands, 1 million deaths a year could be prevented. And this is just looking at hand hygiene, alone, not all the other aspects. Hand washing can reduce the risk of respiratory illness like colds in the general population by 16 to 21%. And then according to the World Health Organization, hand hygiene compliance should be above 91%. And making sure, as close as we can get to that percentage, we're preventing not only illnesses, but we're preventing deaths when we do those things. So just kind of the opposite. How do we prevent outbreaks? Hand hygiene, access to equipment and supplies. One of the biggest, I won't say biggest, but one of the issues that we run into are the night staff in our LTACs and SNFs. I'm not sure about the hospitals, but their access to equipment, access to supplies, everything is available. Everybody's working during the day. But when those people with the keys go home, what happens? Can they access PPE, or is it locked away somewhere and they have to get out with how much they think they're going to need for the day or for the evening? And if they run out, they're just out and they're exposed, not only the patients, but the staff members themselves. Also cleaning equipment, your wipes and things of that nature. Can they access those things at 12 o'clock in the morning? So making sure all staff have access to equipment and supplies throughout the entire day and not just a part of the day. Cleaning and disinfecting of surfaces with EPA approved chemicals. So you always want to make sure that you're using items off of EPA's website. If you're not sure, you can look everything up. And as Faye mentioned, list P or list K for CRs, but you always want to look on the back of those, the wipes or your spray bottles or whatever you're using, to make sure the bugs that you're seeing in your facility that is effective against those. One of the first questions that I ask, after did you test, is what are you cleaning and disinfecting with? And some people, well, where do I find that? Look on the back. We're dealing with nausea and vomiting. We're going to assume norovirus until we find out otherwise. Do you see norovirus on there? If not, you're not doing anything. You're just kind of spreading it around. So making sure your chemicals are effective to what you are seeing. Surveillance, so that's your testing and especially reporting from staff. If you're ill, let your facility know so that they can look at, okay, who did you have contact with within this facility, so we can look at cases to see if they become positive. And development and adherence to facility infection prevention policies. It's great for administration to know the policies and procedures, but when that does not trickle down to the staff, it's just the administration who know the policies and procedures. So that goes back to that regular training of your staff. If there's any changes that occur, making sure they're aware of those changes. As Jim mentioned, like putting things in the break rooms, wherever your staff kind of congregate if they're not there for those meetings. And then also education of night staff, because they're not there during the day when you're having those meetings. So you do have to find a time for your night staff to be educated. Do you come in during their shift to provide their education? Are they coming in during the day? How does that look? And how do you work that out to make sure your morning staff and evening staff have the appropriate education on infection prevention? So suspected or confirmed healthcare associated outbreaks get reported to my staff and I. We're somewhere in the room. I saw you guys introducing yourself, so you can finally put faces to the names that you've been working with. This is our outbreak email, outbreak@health.mv.gov. And even if you have questions, that is a good place to send that, because all of the HAI staff man that outbreak inbox. We go on vacation. Sometimes people are ill. They're going to trainings. So you don't want your questions to sit unanswered. So this is a great way to get a quick answer, because somebody is always accessing that inbox, except for on Saturday and Sunday. During COVID, it was 24/7, but now we have weekends off. So Monday through Friday, I would say 8 to 5, somebody is paying attention to this email address. So you have an outbreak, you've done everything you could do, but something like COVID enters or flu. So what happens? So first you would notify us by email. If you have somebody's number, you can call. We are going to complete what we call an interjurisdictional jurisdictional notification form, or we say INF. And that has all of the information on who called, what's the facility name, what's the address, what's a good contact name, email address, who's been exposed, what type of symptoms are we looking at, has anybody been hospitalized, did anybody die? And then we kind of have a note section where we're just kind of ask you what is going on, how long have these cases been going on, and what type of cleaning and disinfecting have you done, have staff members and visitors been made aware that there is an outbreak going on. And then, what's your census in that area? So if you don't know, we'll just ask for the whole census. For skilled nursing, usually like hospitals, you can tailor it down to a specific area and give us those numbers. But we just kind of want to get an overview of what are you seeing right now. The next thing that will happen, we'll send you some guidance, education from CDC, and we'll set you up with a REDCap account. So if it's something like COVID that's occurring, that account usually stays open. But in REDCap for like norovirus or flu, we have to set up different accounts because those are different outbreaks. So we'll set you up with your REDCap account. You'll get an email to set your account up, your password. Otherwise, we'll just link it to a new account, and then you'll log in with your same username and password. We were going to request laboratory testing, like I said, to identify what is causing the outbreak so we can put a name to it. Sending you that education, make sure your appropriate infection prevention processes are in place. So we'll kind of ask you, like, what are your policies, procedures? What do you have in place? How are you educating staff? Have you done your, I think they're called stand-ins or your huddles? So if those things haven't taken place, then we'll recommend that those things take place. Ensure proper cleaning and disinfectant agents are in use. EBS are such a vital part to the work that we all do in infection prevention. And sometimes they are left out of the conversation, but they really need to be included because if surfaces are contaminated, if they're not aware of what needs to be used, if they're not wearing the appropriate PPE, if they're going from room to room with the same PPE, they are part of the problem instead of the solution. So EBS needs to be educated as well. They need to know by signage what the signs mean, what PPE needs to be used, of course, should be outside the door, how to appropriately don and doff. They need that same level of education as your nurses, CNAs, infection prevention staff. And then maintain close contact with the facility. We're usually going to shoot you an email, just say, hey, I want an update. As you have cases reported, you can send us an email or load those into REDCap. We have a report that goes through every day. So anything new that's entered, we have a list that you'll pop up on. I think that's specific to COVID, but we'll go into your outbreak outbreak account and look and see if you've entered any more cases. And that helps us keep track of everything. We have spreadsheets with formulas so we can do epi curves and all that good stuff and see the process of it. The hardest time to deal with outbreaks are Mother's Day, Father's Day, Memorial Day, 4th of July, Thanksgiving, because when we ask you to, well, it's different now, but pre-COVID, we would ask you to limit visitation. And we would always see a spike, things will start to trend down, and they say, well, can we open back up for whatever holiday is occurring? And we say, no, keep people out because you haven't gone, usually like noro or flu is like 48 days with 48 hours with no new cases. Well, what happens when we come back about Tuesday? Boop, it spikes back up and we say, did you have a party over the weekend? Well, we thought we were good. And so we told you no for a reason. So that's probably a little different now with the things they have in place for COVID, but as much as you can limit people from coming in, because we don't want these things to get out in the community either. And we have seen that where things are circulating in the community, visitors come in, and then now it's circulating within your facility community. So, we don't want it coming into the healthcare community, but we don't want it going out to the general community either. So mainly close contact and then making sure, people are aware, posting signs, so they know what they're coming into. So duty to report. Every once in a while, we have some people that don't like to contact us, and you will get a friendly letter that says you have a duty to report. So there's over 60 communicable diseases and conditions that are required to be reported by NAC. As I mentioned, those that are healthcare acquired come to us. But pretty much everybody is mandated to report: the physicians, veterinarians, dentists, chiropractors, blood banks, nursing homes, the correctional institutions. So when we don't get that report within 24 hours, or we've started you on an outbreak process and it's 3 or 4 days and we haven't heard from you and you haven't told us you have no new cases, then we're like, okay, they're not communicating. So we're going to try to call. We don't get the call back. That's when we have a problem, because that lack of communication is putting patients and even staff at risk, depending on what the outbreak is caused by. So we need that active communication between the HAI staff, the IP staff, and your staff to make sure that we're containing the outbreak, that is not going on for weeks and weeks and weeks, and we can end it as quickly as possible. And just the bullet down here, reports do have to be made within 24 hours of notification, and that notification can come by email, phone call. Our fax is a little wonky, so I would say stick with phone calls and emails. And there is a fine associated with duty to report. But usually once we call people, then KCQC has to get involved, and then they'll call because they don't want the fine. We don't want to go there. So interfacility communication. So when you transfer a patient, their MDRO or other infection status needs to be communicated to the receiving facility. And this is so that they can make sure that they are prepared to take this patient on. They have the staff, they have the PPE and everything that they need to properly care for that patient. You can utilize the transfer form to relay information to the facility or to collect information from the discharging facility. So if you're doing intake, the patient's coming to you, even if it's not like electronic and in your forms, you can use that form to ask those questions to make sure you have those answers beforehand. Communication assists the receiving facility, ensuring they can properly isolate or cohort the patient, utilize appropriate PPE, utilize appropriate precautions, and prevent transmission of the organism within the facility. So that's the link to the form, which you guys have that. So yeah, mine's pretty short. A lot of the information I was going to cover was covered earlier. I went really quick. So any questions? Yes. So they can hear you up north.
If I have a resident who is admitted to my facility and it's suspected that they have auris, but the hospital hasn't confirmed, is there a way for me to confirm for myself?
So we do have testing available through our state lab.
Mm-hmm.
So you will want to isolate that patient. We can get you the swabs through our state lab. You can swab them and then get those results yourself.
Okay.
And so that's another thing that the transfer form assists with, because sometimes they have tested them, but they haven't received the test before they came to your facility. So they can put pending on there. You can ask that question: Are you pending any test results for this person? And if yes, then to isolate them until you get those results, and then you can move them in general population if they're okay, or keep them isolated, or whatever you need to do to keep them protected, staff protected, and other patients protected.
Okay. So you did answer my question, but if, for example, a nurse took a report and wrote down the auris, that's what he wrote on the report, but there's nothing in the paperwork, there's nothing anywhere pending, and we haven't got any results back, but the patient is in isolation. So how do I obtain those results, or I should just retest it?
Well, you can contact the facility that sent them to you, because if they're sending that report, then there should be a person of contact on there. That's another thing you can put on the transfer form: who filled out the form and what is their contact information. So if you have any questions, you can call them back. But if you don't have that communication, or you can't reach anybody, then yes, you can screen them yourself and get those results yourself.
Okay. All right. Thank you.
Hi, Gwen.
Hi, Kamisha. So kind of to tag on to what she said, is there ever going to be a database where we can look patients up who have been tested throughout the state of Nevada for C. auris or any of the CRE, CRO?
Please contact the people above me because I have been trying to do that for years. So
I would love to help you because that is a
Illinois,
huge frustration for us.
yes.
A lot of times the interfacility transfer forms do not come with patients. It is very difficult to get those results from other facilities. Most of the time, because we're acute care, so we take patients based on the fact that they need to be upgraded to a higher level of care. And to get those results is really, really difficult. So I know that we're not perfect at sending the forms always to the long-term and SNFs, but if there's anything that we could do to make that process better for everybody, that would be fantastic.
I'm going to see if I get a petition started there. Because I honestly have been trying to get that. So Illinois has a system called XDRO, and that's exactly what it is. So those patients are in there for any MDRO. We get pings if somebody is entered, but then the facilities have access to, if you get a patient in, you can put their name in, date of birth, and you can look them up to see if they have a history of something. So we are trying to work on, I think they had a meeting about it yesterday, but I was in Atlanta for a training. Because Washoe County is actually, I think they're able to get access to it. So we're trying to do that also. But if there's something I can get for like facility advocacy, I will let you guys know because I really feel like that will help everybody to just be able to look up whoever you want to look up. Yeah. I agree. And this recording is going to go up on the website. So they'll be able to hear that comment and say, see, the people want it. Give the people what they want. Any other questions? Anything up north or in the chat for virtual attendees?
So one of our issue is we do have a patient that would be admitted and said that the patient has C. auris with no confirmed result. And then this patient needs to go to dialysis. And sometimes dialysis would call us and say, before we put this patient into a C. auris center, can you provide us the result? So that is one of the things that I tackle twice already. So I'm grateful that I do have a good contact with my state epidemiologist and they help me a lot. But if there's a way how to expedite the result for us to receive it, but I make sure that that patient is already in contact ISO. So I think the issue here is the dialysis. For some reason, there's a communication barrier there that they need to have that result before they do anything. So what can we do to make this a little bit better?
It would depend on where they were tested. Like if they're at the state lab, then we can get access to that. But if they were tested at the facility, you would have to contact the facility to get the physical laboratory result. And like I said, I get a weekly report, so it depends on when they were tested. They might be on the report that I have for that time frame within that past week or two. But other than that, you have to contact the facility. Like the lab stuff is kind of easy for us because we can just shoot them an email with the name and date of birth, and they can send us the result back. But if they got tested at a facility, then that's something you have to communicate with them because we wouldn't have access to that information.
Hey, Kamisha, this is Jen up north. Hey, Viv, thanks for speaking up. We are working, I'm going to throw Danielle under the bus. Danielle Charles is currently working with the dialysis centers and we'll be doing ICARs at their facility to engage them in their practices and how to accept these patients without requiring that particular lab. As we know, it takes time, especially if it's pending. They should not be denying care for these patients just because they do not have a lab slip in front of them. So that is something that we are following up with the dialysis facilities. But back to Kamisha too, if you do have questions on those patients, call us and we can get with the HAI team if you can't get a hold of your contact and we'll look them up. Heck, we'll call the state lab and verify if they even have the record to see if that particular person is positive or colonized and where that result came from. The biggest thing I think we also need to push for, except for that system, which I am wholeheartedly approving of, is having those talks, making sure your intake coordinator is aware of the questions to ask and not blatantly accept patients without making sure that those questions are answered. Because facilities have to have it in a packet. It does not say it needs to be on the first page. So as of right now, we are getting a lot of EMR packets for discharge, and it's on page 17 or page 24. And unfortunately, talking with case management departments, that is how the system is set up. So they cannot make changes to that. So, utilizing that interfacility transfer form with answering those questions is important on both ends.
I have another question. So it is pretty common that there's a lot of facilities who are refusing to take patients when they're able to leave the acute care facility due to isolation purposes or maybe treatment or different things like that. And since we have everybody from all walks of healthcare here today, just wondering if there's any input that anybody could give as to why we are doing this or what we can do to make the process better. Because we have a lot of patients that end up being residents at the hospital because we can't get them transferred out. So just wondering, as we have a big group of individuals here, if anybody has any kind of insight on that.
Anybody?
Isolation beds sometimes are limited, but when we hear we don't take isolation patients, and we have these patients with auris or CREs or different things that they're going to be in isolation, colonized or infected, and then we hear that there's nobody that'll take an isolation patient, or treatment's too expensive, so we can't take that patient, or those types of things. They end up being residents at the acute care centers, which is unfair to the patients, unfair to the hospital settings, because then we can't take other patients that need that acute care attention. So I just was kind of hoping that maybe we could have a little conversation and discuss what we can do to make it a better situation for all of us.
Hey, Kamisha, this is Jen again. So we have had contact and we do have meetings with Marcia Brown from the Nevada Hospital Association in regards to these transfers. And there's a lot at stake and there's a lot of other things. So if a patient or if a facility is just blatantly saying they do not take isolation patients, we need to be informed of that so that we can escalate that to the proper channels. However, upon further review though, case management will say, oh, they said they wouldn't take an isolation patient. Come to find out, the facility didn't even take that type of insurance, aside from the fact that they did have CRs. And so there's a lot of different things that a facility can deny on outside of it being isolation, but saying we deny for isolation purposes isn't appropriate. So we would want to find that out, but we do encourage you to do root cause analysis, because upon further review of that, we've identified internal facility issues with communication, whereas case management didn't say they were CRS or CPO or any of that, and the patient was transferred out and presented to the facility and they didn't have a single occupancy room. So then the patient gets bounced back to the ER. So we do encourage root cause analysis on your own part and with the facility you're trying to transfer to. But if truly the statement is we will not take them, they have CRS, we do want to be involved so that we can escalate that to the proper channels with HCQC.
Hi, I also wanted to bring up College Park. Actually talked about isolation, cohorting. And I think that is such a good example too. And thank you, Jen, by the way. Jen is absolutely right. When we get contacted about these situations, we like to respond. I'll go and visit the facility. I'll go and sit and discuss the root cause analysis and really involve us. We are happy to do this and help you guys along the way. And it's so great that College Park brought this up earlier in my presentation, that they're really struggling with their census. And we're finding, even when I do my on-site visits, that they're cohorting people because, you know, they're limited on space and they're limited on staff. And so sometimes, you know, we'll look at their bed capacity and say, well, you're a major facility, you have a massive capacity. And then in further discussions, we find out, but we don't have the staff for that capacity. We have shortages. So, you know, as HCQC, you know, if you look, we're licensed for 180 beds or so, but that's not our actual capacity at that point. And so we have some of those discussions and find out they're not denying based on that, they're not willing to take someone under precautions, but there are other reasons involved, meaning, well, all of our rooms have someone with a vent, and we're not sure if we're willing to take someone to expose that and cohort them, or we really don't have the staff to increase our census to a larger size, or a variety of other factors. But those conversations need to be had as well, because on the flip side, I've investigated situations and found that some facilities did not have infection prevention and control policies and practices for C. auris. And without that preparation, without a plan, without the training, they have misinformation, disinformation, and frankly, their staff were not prepared. And so they weren't ready. So we are finding that everywhere, and our team is just trying to educate as much as possible and do our best so everyone has a plan, everybody's prepared, and then, like Jen said, if we can be more transparent about the reasons for the denial, that also helps on both ends.
Thank you, Faye. Any other comments in regards to that question? I don't see anything in the chat. Jen, do you have anything up north?
No. No, sorry, I didn't turn the mic back on.
Are there any other questions or comments? And it don't have to be just about outbreaks. It could be about any of the 4 presentations that you have seen today.
On behalf of College Park. And cohorting. So I've got the CRS and, I've got that part of it. We're good. If we're talking the CREs, the carbapenem-resistant enterobacterials, again, we're looking at, I've got a CRE that's a Klebsiella, a CRE that's a Pseudomonas, a CRE that's an E. coli, and they've got all these things, and we're, again, still trying to figure out how we can cohort those. So if it's a CRE, do we have to cohort, can we cohort CREs together, or do we have to limit saying, no, this has to be a Klebsiella with a Klebsiella, because that's where we start. We're getting people that have CRS plus Klebsiella, CRS plus Pseudomonas, CRS plus Klebsiella and Pseudomonas, and we're trying to keep track. Like, we update our roster on an almost daily basis now to see who has what and where they're going, and it's like a game of Tetris that we're having to play every day to get that next admission in. So where do we go with that?
I'm gonna pass that to Faye. I know in the past, I think we called CDC about it, and as long as they did not have like an NDM or something like that, those CREs you could, but if it was like a CRE KPC, CRE NDM, CRE OXA48, those could not be cohorted with those that did not have a carbapenemase. But I am more on management now and have not talked to CDC in a while. So Faye, any update on that? I feel like a news.
Yeah, Kamisha, actually, that's such a great point, because, and basically, from our standpoint, do your best. And I had this conversation with the CDC in our recent visit too, because of the issue with so many complex MDROs and those with the different resistant genes, and how to separate them and understand that. And, a lot of these facilities, are they even tracking those test results of which genes they have? Because, like, we know these culture reports, susceptibility reports, PCR reports, are those even getting back to the long-term care facilities? Do they have that information? And unless you know if they're KPC positive, it gets very complicated. So do your best to keep the vulnerable away and do your best to cohort those with the same the same pathogen and the same resistance. So if you have that information, if they're KPC positive, then do your best to cohort with the same genes and the same resistance. But that is difficult, and do your best and try to keep the vulnerable as isolated as possible.
And to add to Faye, I always like to say rainbows and unicorns. Do your best and back away from it the opposite way. So we all want the perfect world where everybody has a single room, like Northern Nevada State Veterans Home. They have single rooms and single bathrooms, and it's so easy, but most places don't have that. So then you work your way backwards by figuring out what is the next best stage to keep everybody safe.
All right, any other questions or comments? That was a great question, thank you. Yep.
Hi, Skip Katipunan, Infection Prevention at UMC. Just listening to all of this and knowing the conversations that are happening at our hospital, I have no idea what an MDRO is. Like, I used to. I thought I did, and now we're having all these conversations that are like blowing my mind. And Kelly, thank you for your presentation today. It was great. It was enlightening. I was like, oh, that's what a porin is. Oh, so I'm also a big advocate of research, and I guess I just wanted to pontificate a moment and say, like, there are some really smart people in this room and up north, and as the complexity of our patients' MDRO statuses continues to grow in ways that we're not equipped to handle, I feel like, I guess I just wanted to put a call out, like people I hope are thinking of opportunities to document what it is that they're doing at their facilities as we're doing the same, because even in acute care, we have, I don't know, UMC's a 400 blah, blah, blah bed hospital, and I mean, we've got like 80 patients in isolation at any time, and the complexities of their isolation as well are really big. The concomitant infections with MDROs, complex MDROs, is really out of hand. And I guess I just wonder that we don't have opportunity to do some research or poster presentations or QI projects that say like, hey, this is what we decided to do in a crunch and this is how it turned out, so that we can pump out some data in the infection prevention world that we can all take a look at and maybe make some decisions about in the long term.
And I can support a training on it. You can present. I think that's great because sometimes we feel like in silos, and I'm the only one going through this when we're all going through it. I mean, the amount of reports, like when I get our, what did they say? It's not a grant application, it's a cooperative agreement application. And it's like, you want us to do more work? Like Jim mentioned, now we're taking on dialysis facilities and educating them. And I understand why they need to be educated, but the stuff that we receive, I'm like, what is this? With COVID, everybody knows who to report to now, and testing and resources. So we, like you said, Skip, we are seeing some stuff. Like I remember when CR started and it was in the midst of Omicron. So what you said during your presentation was correct, because those first cases came when Omicron hit. And when you're calling a facility and they're trying to keep people alive because everybody's coming in with COVID, and you're like, hey, you got CRS, I need you to do a PPS. That was not the priority. And by the time Omicron died down, it was like, okay, what did you call me about again? It's like, well, it's everywhere now. And what are we going to do about it? And I did a presentation for the Nevada Healthcare Association last week. And it's like, please don't get it in the north, because once it's out, and it's so hard to contain. And, trying to get support and talking to CDC and trying to work with the facilities. And, there's challenges with PPE, there's challenges with staffing. Like there is a lot going on. And it's going to take us working together to get through it, how we did with COVID, to get through CRs and whatever's coming next, because we all know, unfortunately, something else is coming in. Now we have the tridemic because it's flu season and all that stuff. I was trying to do this earlier in the year to avoid us being in a room during flu season. But yeah, I mean, use your resources. Is there anything that we can help you with, or reaching out to the hospitals? I know we tried to do like a mentor thing pre-COVID, where maybe somebody with a hospital could be like a mentor-mentee thing. If you didn't have those access to resources and ID docs and things like that, that you could call on to get assistance with patients that you're seeing. So we can start that kind of stuff up. We just need participation from the facilities. I know you guys are all busy and we're busy too, but to not utilize the resources that we have in the South and in the North just kind of leaves us in the same situation. And our patients need us, we need each other. And yes, I think that's all I have to say. Yes.
Hi. I'm Lisa at Valley Hospital. I had a question regarding Candida auris colonization for patients coming from home, as well as going to the home environment. We're seeing more of that come in. Is there any analytics that anyone's doing on that to show what we could be doing to help them?
So no analytics that we're doing in the state. I know CDC is supposed to be updating their resources and education and things like that. So I'm waiting on them to give us new stuff. But it's kind of, everybody is figuring this out as we go. We do have education on our website for family members and for the home environment of what is CRs, what does that mean for your family and things like that. How do you contain within a home? So we do have that kind of information on our website that can be given to patients, but we haven't done any analytics on patients coming from home and going back into the home and they're colonized.
Hi, my name is Ambry. I'm a Master of Public Health student at UNLV. My question is related to Skip's question about people being in silos and opening up communication. I love the idea of QI projects, absolutely, but just thinking in general about sharing information, are there any community of practice organizations like at the state or regional or even national level that you know of that might facilitate that type of communication and improvement? Go ahead.
So we do have community of practice through CDC for each individual state. We are looking at getting something like that started up for Nevada. We have our CFO, don't ask me what that stands for, we're in a world of acronyms, but she was assigned to our state from CDC, and that was one of the things, her ideas. So we just we needed an ID doc and a pharmacist to assist on those calls, but to have something where you all can get on and talk together, talk about what you're seeing in your facilities, and then glean from each other on how you're overcoming those types of challenges. So that is something that we are working on. I believe Jeannie is on the call. So I'm sure she's happy to hear that, that is something that is wanted, especially down here in the Valley, but, in the state, so that we can provide that service.
Hi, Kanisha, this is Jeannie. Can you hear me?
Yes.
Thank you so much for the person who asked that question. While we've got a bunch of folks in the room, I'm wondering what kind of platform you think would be helpful for a community of practice type group. Would periodic virtual meetings be helpful, or would you prefer some sort of, like in-person meetings? What does the group think about how we should facilitate this ongoing communication? Because I know there has been some meetings that have been organized by the Hospital Association, and I think we do have some discussion there, but does anybody have any ideas about how they would like to see a community of practice structured?
I'm going to punt that to the people who actually work in this field.
I mean, we could do something like this where we have a hybrid setting. So there's a meeting place in the north, meeting place in the south, and then virtual for those who can't attend in person. We can do that, or we could do just Teams meeting. I know the virtual is kind of because we all know when you attend something virtual and then somebody calls on you or emails pop up or text messages, then your attention is gone. So you're hearing it, but you're not really containing the information that's being given. So if this type of setting is something that you all like, I'm more than happy to set that up. I don't know how frequent it has to be because we did have to pay to use this room. Budget is limited. But whatever I can get together, like we could do a virtual more frequently and then maybe quarterly do it in person type meeting. But like you guys let us know what works for you and what you would like to see. And then we'll see how we can get that going.
So I'm Julie. I'm with the UNLV, and we are with School of Public Health, and we are working on the grant with the Department of Health with the HAI. One of the things I know right now, we are waiting to be able to get access to REDCap and to NSHN to get data. We've got a team of grad students who are biostatisticians, right, that are doing. Come on, you take credit, but they, and so really we, if people are able to provide data, we would love to take a look, especially at, facility specific data. I don't want to overextend because we do not have Dr. Labus here with us, but I do know that, a lot of us here are very interested in, facility level data and other things. And so we would love to be able to, get involved in that as well. If there are facilities and different people that are looking at providing, even de-identified data for us to look at, I think that would be a great place for us, because I know that's one of the challenges our biostats team have had, is trying to find some data, some strong data here in the state that we can start taking a look at.
Well, I'm the person who will give you NHSN and REDCap access. So if you have those names and emails, I can do that tomorrow. Because we're just waiting on Dr. Labus to give me the names and emails. So if you can provide that information, I'll give you my email address and send it to me, and I can get that going. NHSN takes a little bit longer, but REDCap is as soon as I do it. Any other comments regarding community of practice, challenges, outbreaks, CRs?
Kamisha, this is Jeannie. I just have one more question regarding the community of practice. I feel like some kind of chat channel could be very helpful, because folks could just throw out a question to the community and then receive answers as people see it, and if anybody has experience for that particular thing. I am hesitant on that because, of course, we could never put PHI or anything like that on that channel, and I think it just could become sort of burdensome to monitor. But if there's, if the healthcare community thinks that that would be of value, we could put some more effort into looking at platforms. Something, potentially Slack is something that CDC uses for example, their NSSP community of practice for public health officials. So does anybody have thoughts about that? Would some kind of platform where we can share resources and chat with other members of the community, is that something that you think sounds like it might be helpful, or do you think sticking with meetings might be of better value?
I saw one head nod. The others?
Thanks for the head nod, Tally, Kamisha.
So the comment down here is chat is more real time, so that would be helpful. And then the meetings to summarize what was discussed on the chat.
Okay, cool. So perhaps some kind of combination of both. We'll keep looking into that. If anybody has thoughts about that, please reach out. I'll put my email in the chat. And yeah, would love to have all of your ideas. Thank you. And also, if anybody is interested in kind of spearheading this community of practice, it's more than I have the bandwidth for. So definitely looking for community partners. Thank you.
Thanks, Jeannie. Okay, we are almost to 3, so I'm trying something new. So we did this at our training with CDC. It's a poll everywhere. So we have 3 questions on a poll to see how you answered. So like I said, I'm new at this, and So you can scan the QR code with your phone or use the address up there, thepollev.com, and then my name, 585, to get access to the survey and then answer the questions, and then we'll look at the responses that we received. So the first question is, what is the current hand hygiene rate for healthcare personnel in the US? So this is how everybody has answered thus far. So I'll give you a little bit of time, and then we'll go through the poll questions and we'll discuss. Did that work? This is as big as I can get it. Is everybody on the poll? Or I change the screen? And Shreya, if there's any comments in the chat, let me know because I can't see it right now. And let me know if it lets you see all three of the questions or if you're just seeing that first one on hand hygiene or not. Oh. That's it. This is my first time at this. Okay. I'm gonna stop sharing for a moment. Work with me. I think it's off because of it's saying I have 84 responses, but there's only 26 surveys. I will have to play with it some more, but we'll go with what we have. Is it working now? Oh, okay. Okay, so it should allow you to do it now. Okay, I think you guys heard this one enough during the presentation. The current hand hygiene rate for healthcare personnel in the US is 50%. So the next question is, what percentage of skilled nursing facility patients are readmitted to the hospital within 30 days? 25%, 10%, 50%, or 5%? All right. So the answer to this one is 25%. 25% of SNF patients are readmitted to the hospital within 30 days. And then our third question is, well, how does readmission affect the patient's mortality rate within 6 months of the readmission? So there is no effect. It quadruples their mortality rate or it doubles their mortality rate. I think most people have answered. So it actually quadruples their mortality rate. And so we wanted to ask these questions to start a conversation on what can be done to increase hand hygiene compliance within healthcare facilities, and how do we stop readmission of patients, or at least decrease it so that we can decrease that mortality rate within our patients. So what have you all done? And Jen, if you have any comments. Jen graciously provided me these wonderful questions, so thank you very much. But what have you all done to increase hand hygiene compliance, or how do you address hand hygiene compliance in your facility?
So we just got some glow germ in yesterday, so we're going to start using it as a demonstration of good hand hygiene and how things can spread.
It's good also for EVS. So we've used it on our iCars where we go into the room and we mark certain high-touch surfaces. Of course, they don't know what we've marked. We allow the EVS staff to go in, clean and disinfect the room how they normally do. And I think we usually ask them to do like well, not a terminal clean because that would take forever, but just when they go in to do a cleaning, and then we come out and show them how many of the marks they removed, or if the marks still there. And that really gives them, a visual on, how you have to rub the surfaces, the dwell time. And as Jen mentioned, I meant to touch on this in mine. Please check the chemicals and disinfectants, the cleaners and disinfectants that you're using, the disinfectants more so. And looking at the dwell time, I know we dealt with the CRS outbreak a while ago, and it really went back to the disinfectant agent that was being used. It didn't have a claim for CRE, and the dwell time was like 15 minutes. And this was during the summertime. So of course that wasn't effective because nothing is staying wet here for 15 minutes. Also looking at if you're using the sprays, usually those don't stay wet because they'll spray the surface and then they wipe it right off. So it doesn't stay on there. So look at those dwell times. The lower the dwell time, the better you're going to have of getting that surface clean and disinfected. And then also they have to be clean first and then disinfected. So Glow Germ was really a great tool for us to use for that. I just bought the swabs for my staff so they can swab, and throw away. Don't use the pen because then you're just spreading stuff. But GloGerm is good. And then with CDC, they did a trainer with us in August. And one thing they did with us was putting red paint on our hands and had us act like we were washing our hands. And then everywhere when we looked, we had places that the paint did not touch. So like if you were washing your hands or using sanitizer, you see where you're missing areas on your hands. And that was, something fun to do with the staff. Wouldn't recommend doing it over carpet because it was red paint. But, those type of interactive activities where they can say, oh, yeah, I'm getting it good. And then you show them and it's like, no, not really. And this is why we need to pay attention, to this practice of infection prevention. Anybody else? What have you guys used for increasing hand hygiene compliance within your facility? Oh, wait for the mic so they can hear you in the north.
We do communicate with my center of supply, who is the one who distribute our alcohol and alcohol sanitizer. So I asked him how many is it that he put it in there on the floor for one day. So that way we know for sure that this staff are using it. So if he tells me, what, we run out within this week, it looks like even the bleach for CRS, sometimes he'll tell me like, I ran out this week, it looks like we don't even have one. We end up going to Home Depot just to buy some. So that when I know that my staff are using and washing their hands and they're disinfecting the area, and especially the CRS room. So there's another surveillance that I use as well. So I talk to the central supplies a lot and environmental as well.
And I know Faye mentioned how you guys can use the iCar tool. So one thing we do when we do the iCars, we walk by all of those hand sanitizer dispensers to see if they're working. And, the battery is out or the sanitizer has run out or the distance between them. There's one here and there's one way at the end of the hall. So what happens to all the rooms in between that, especially the older facilities where those types of items aren't in the room? So those are all things to look at in improving your hand hygiene compliance, having that access to resources to make sure they are in prime areas where your staff can utilize them. And I know, especially with skilled nursing because they live there, but I had a facility tell me that like their corporate office didn't want to increase the number of hand sanitizers because they wanted to feel like a home environment. So if you need us to talk to corporate so they can understand those measures, we do get on those calls. We even had CDC get on those calls with corporate, but you guys have to let us know, what kind of challenges you're running into where you're trying to enforce infection prevention and control, and they don't really understand the aspects of that and the safety of your patients. So if you're running into challenges like that, just let us know, and we are more than happy to jump on those calls and provide education in that way as well.
And Kamisha, this is Jen. Another thing is really focusing on that culture of change. Really getting everybody engaged to know that it's for the right reasons, so it's not punitive. So if you see somebody in the hallway that's not doing appropriate hand hygiene, rather than calling them out and making a spectacle of it, creating that environment to say, oh, we missed the step, and like making it something that is learnable. So if you're called out by not doing hand hygiene from somebody that, a lot of times only managers will call somebody out, whereas we really need to make it where if a CNA sees it, even with the doctor, we need to be saying these things and saying, hey, did you forget to do your hand hygiene? This is really important in our community. But that has to come from above as well. So really doing that whole closure of loop process to get that change to be productive.
Any other comments?
Faye recommended to us to get those hand sanitizers, single hand sanitizer. Is that right? So, yeah, thank you. We actually bought that and it helps the staff, especially also our wound nurse when they go in. So I'm in the process of educating the staff to use that a lot and have it provided to them in their pocket. So that way it's right there. And it's only a single-handed hand sanitizer that also works. And I also do a secret, I call it a secret surveillance staff, which is we do have a guardian angels, but I also, the night shift, since we're not there, I call it a secret staff that would go around and to monitor the staff at night. So that seems to work so far.
Good.
So it's a good thing. And then that way she can also, I will meet with her the following day or 2 days after, and then I will educate certain staff that are not following and non-compliant. So that way I can have a one-on-one, sometimes a huddle education with hand hygiene. Thank
Now,
you.
have you looked at your hand hygiene compliance before you've implemented these changes and after?
Yes, I actually did. And I noticed that the staff was also provided a feedback that they do like the single-handed hand sanitizer. And this time I noticed that my units are more, I could see that they are more like they're using their own perspective and say, you know what, I did my hand hygiene, I go home and I know I did my part. So they provide a feedback. I do listen to that, and I think I appreciate that when I did an ICAR with Faye and Soraya and Sharir. So I appreciate that part. Thank you.
And the ICARs are not like a punitive thing or you have problems and that's why we're coming out. We can do those also as a preventative aspect. So to help you identify what the gaps are in your facility and then help you, look at resources on how you can close those gaps. So you can request an ICAR from our IP staff and they'll come out, and as well as, my staff, Shreya is one of my staff members, to come out and do the ICARs and to help you as far as closing infection prevention gaps in your facility. So we prefer to do the preventative ones versus the reactive ones because they're, working before, things may get out of hand. So on the readmission question, Jen, I will turn that over to you because you're more of an expert on that one than me, as far as what questions to ask.
Oh, which questions to ask? I mean, the biggest thing is going back and looking at the risk assessment of each individual patient. We've really got to focus on what they come in with and doing that assessment with the bedside nurse on admit. So do they have devices? Are those devices required? The number one return rate is sepsis. And sepsis is usually caused due to indwelling devices. So if they have devices from the acute care, before you even admit them into the facility, see if that's something that can be discharged while at the acute care prior to admitting them to your facility. If that's not doable, then you need to have a policy in place as to what that looks like when the patient admits to your facility on when to discharge or when to reassess. And it should be done with the bedside nurse, with the leadership, with your medical officer, that whoever's in charge, or the doctor on that day. The quicker you get them out, the lower the chance of an infection. And especially because we know our hand hygiene rates are so low, making sure you have the proper tools at your disposal when doing proper care of these devices. So I know Viv mentioned the single packs of alcohol-based hand sanitizer. We actually utilize those in our wound care kits and our central line kits. They came in them. So it's a teeny little pack, it fits busted open, and it's one time and you throw it away. So you're not recontaminating the bottle or anything like that, and it can come in the kits. So just making sure that each step along the way, whatever device you have on the patient, you're caring for them appropriately, and you're de-seeing them as quickly as possible, and that then lowers their chances of returning. Along with that, it's accepting the right patients. And that goes back to asking the questions prior to admit about their status. Are they appropriate for your level of care? Do you have the staff to care for them and make sure that it's a safe care? So it's a big circle, but all of it comes back to communication. So we really need to start having better fluid communication from acute care to LTAC to skilled nursing and even down to assisted living and group homes. Because if you send a patient out and they don't feel capable of caring for them, they'll go right back to the hospital. And then we create this big cycle of people being in the hospital for no need.
Jen, we lost you.
Yeah, I muted.
We didn't get
Is-
the
I
last
mean-
piece of that.
Oh, just we need to have better communication. I mean, I know we continue to talk about it, but, with staffing shortages, I get that it's difficult to get somebody on the phone or to get answers, but, you know, if we make it a point to really start asking the questions before admit and making sure we have those answers, we can accept patients at lower levels of care that are safe, and the chances will lower for readmission if we know what we're getting. But if we're given a packet of 84 pages and we don't know the complexity of the patient because it's buried in there, people do not have time to read through that whole packet. And so a skilled nursing might accept a patient that is totally inappropriate for their level of care. And then that patient will bounce back. And it not only creates a burden on the hospital, but it creates a burden on our overall healthcare cost. Because a readmitting patient means that the hospital is not getting paid for that return patient within 30 days. And there is a bigger chance that the patient's going to have more out of care costs. So we're only creating more hardships all the way around.
Do we have any other questions or comments?
Thank you, Jen. In my presentation, I did kind of bring up that feedback should be organizational data, not just staff competency data, because there are systematic gaps. And I'm not sure exactly what position our audience is, if you're mostly IP positions or administrators, but the facilities should be collecting data on their entire organization as a whole and identifying systematic gaps so that this doesn't just all fall on the IP. You know, we're saying communicate more, communicate more. Well, this information, the data can really go back to our leadership and to our administrators, to our corporate, and to those people that are having higher conversations to say, look at our return admission rate. Look at how much that's costing us directly and indirectly. So really, you know, if we need to bring up systematic costs here that are happening to these facilities, let's get that data and let's continue to have those conversations with administrators and with corporate. And again, like Kamisha said, we are always willing to help you with those conversations. I'm not sure if most of you are just IPs or where your positions are in your facility, but we are happy to help you in any way possible with those conversations. I sit with administrators, not just IPs, on my visits, you know, and communicate those gaps, because it's not just your staff need to do better at communication, this or that. What are these systematic issues that we can fix as an organization?
In Bay, there is a CMS regulation now that facilities will start to be fined based off of their readmission rates. So there will be penalties associated to higher readmission levels from the acute care standpoint, which would then push off even more healthcare costs, you know, further down the line of having issues. I don't know if skilled nursing facilities are going to be included in that penalty fee at this point, but the acute cares definitely will be included with that penalty fee.
Alrighty, thank you all for your questions, for your feedback. They should be passing out the evaluations up north. They've been passed out here in the south. So please complete your evaluation for this training. Please provide your comments on subject matter that you'd like for us to cover. If there's CUs that you need that were not offered today, let us know what type of CUs you would need so we can try to have access to that and get those available for you for our next training. Once you complete your CU application form, you can pass them in the south. My staff are here at the door, And then Paying will assist you with your CU certificates. Those are available for nurses, nursing home administrators, and residential care administrators. We do have a certificate of attendance. They just changed the law for unlicensed caregivers that need to show that you received training, so much training throughout the year. So if you need a certificate of attendance to show that you were here to serve for that, that is also available. If you attended virtually, I'm in the process of putting my information in the chat. Excuse me, please email me and I will get you your evaluation. And then once I receive that back, then I can send you the appropriate certificate of completion for CUs or attendance. I want to thank everybody for their attendance, for coming out with us. It's good to see everybody that I have here and to hear from those in the north and those virtually. Thank you for all you do. I know it's been a long call since COVID, but thank you all for everything that you do.
And I just wanted to say, I've left my business card at the reception desk where Pang is sitting. So if any of you would like my card, I'll leave some there.